Computer. Hello, welcome. Welcome everyone. We have very talented list of speakers, panelists and advisors for this virtual side event on the margins of 11th Multi-Stakeholder Forum of Science, Technology and Innovation, STI Forum. Names, email addresses, and short bio of the speakers are available on the website. The link to access all this information is also available on the chat box. If you have any questions for the speakers, please feel free to contact them directly. But wait for the session to be over and write your questions in the chat box. We request the audience to keep your speakers and picture muted during the session to see the speakers and hear them properly. In view of the scale of today's global challenges and the great potential of science, technology, and innovation to deliver responses, global cooperation in science, technology, innovation, STI, is indispensable to achieve health and education for all. Global partnerships around the STI are necessary to mobilize financial and knowledge resources from governments, businesses, academia, and unfold the potential of all Sustainable Developmental Goals SDGs. To strengthen global trust in STI and achieve United Nations 2030 agenda, scientific community needs to communicate their work and uncertainty of the specific scientific process more effectively with the public. The title of today's side event is Artificial Intelligence in Clinical, Medical, and Surgical Practice. So let's get it started. All right, here we go. All right. What is AI? AI is technology that enables computers and machines to perform complex tasks that are typically associated with human intelligence. When people talk about AI today, they are usually referring to generative AI, a type of AI system that can create writing, images, videos, and computer code. Even more specifically, they are talking about AI chatbot assistants and other conversational AI systems powered by large language models. Sophisticated software trained on vast amount of human language data. These systems range from general purpose tools like ChatGPT and Claude to specialized characters and agents made for specific interactions. Despite widespread adoption, the story of AI is very much still unfolding, and the technology is far from perfect. This is today's agenda. Number one, aligning AI with social objectives, prioritizing ethics and societal impacts, and guiding AI for shared prosperity. Need for global AI hub. Open AI, open data, open science, and open source models. If we truly want to understand in what ways we can say AI thinks, then we really need to make progress on them. The sky really is the limit when it comes to the question, what can you do with AI? AI tools can be incredibly useful for quickly synthesizing large amounts of data, breaking down complex topics in a simple way, and pulling key themes from text like summarizing a dense research paper or making sense of your scattered notes. These tools can also work with the images and videos, and answers you get will only be as good as the prompt you give. With AI, context is everything. If you want help authoring a difficult email to a colleague, make sure to first explain the situation, the relationship dynamics, what routes you already have tried, the tone you want to strike, and the outcome for which you are hoping. Another issue, AI tools also are not yet fully reliable to terms of accuracy. So you should not depend on them for something crucial like health or legal advice. Much of AI generated content is harmless, although some of it is of low quality, low effort, high volume material referred to as AI slop. We aim to enable stakeholders to take shared responsibility based on the global and intellectual dialogue. Emerging uses of AI in health sector is inevitable. The most important thing to know is that AI is being created by people, and we get to decide whether or not to use it, trust it, and regulate it. AI can find new uses for existing drugs, helping to treat the rare diseases, including the one that almost killed us in the past. Women have a right to safe motherhood, and we recommend efforts to improve curricula would be more successful if national societies support training according to their country's objectives and apply them in reducing maternal perinatal mortality and increase availability of family planning services. When we work together, we as humanity can harness science, technology, and innovation to benefit us all. Government should create the conditions for accessible, affordable, and high quality digital infrastructure and support STI development. What can we achieve with open science and open AI? It can unlock knowledge and resources and create open innovation. An AI focused center or the network could serve as a global hub for AI capacity building, technology transfer, and technical assistance for developing countries. Our partners' voices. We wish to bring to your attention to this side event organized by us last year titled Emerging Health Technologies and Health Development. Link has been provided to you. Please review at your convenience. Here is the link. Another summary and side event published by the Commission of uh, Social Development, CSOCD 62, titled Towards Education and Health for All. It was published by Division for Inclusive Social Development DISD. Please review at your convenience, and here is the link. International partnerships should aim to closing gaps in knowledge capabilities that hamper effective technology transfer. Current trends indicate that world is not on the track to achieving the sustainable developmental goals, but science-based tools can help drive change. Advanced digital technologies are set to change the way we work and live. While scientific evidence is key in addressing complex global challenges, science is not a cure for all and for everyone. Technological advancements can improve living conditions, but they also often increase inequalities in certain instances, leading to increased frustration among those left behind. Here is a summary and the takeaway messages. Technology leadership by the private sector is not new. What is new to AI? Unprecedented level of control and understanding that private companies have uh, over the control of the technology. Imbalance limits the ability of governments to steer AI development in the public interest, and AI projects aimed at social impact may feel the pressures of profit motive and capital markets. Well, thank you very much. Here is my email. Feel free to contact me for any clarification. Thank you. All right. Here it is. It is indeed my pleasure to hand over the floor to Dr. Colleen Kraft, Professor of Pediatrics at University of Southern California, Los Angeles Children's Hospital. She was also 2018 President of American Academy of Pediatrics. Her presentation is on artificial intelligence and new pediatric devices.
Okay.
Okay.
Let me see if I can share my screen now. Okay, can we see it okay?
Yes.
Oh, great. Okay. So we're going to talk a little bit about just some of the applications of artificial intelligence as it pertains to pediatric technology, which is really a very exciting piece of things because we are looking to see how new pediatric technology that is really facilitated by artificial intelligence and machine learning can help in the diagnosis and treatment and self-management of pediatric conditions. And then finally, to appreciate the limitations of this technology and the ongoing need for patient advocacy. So what we have in pediatrics are lots of gaps in diagnosis. We have lots of kids, up to 15% of kids have a developmental disability, but we don't have the physicians and the therapists who can make those diagnoses. We have lots of kids with genetic phenotypes, but not enough geneticists to make those diagnoses. Similar with X-ray and CT and MRI, we have a lot of the technology, but kids are waiting in line in order to be diagnosed. We have gaps in treatment. We have a number of kids who have strabismus, which is in vernacular lazy eye, that we don't have enough ophthalmologists to see these kids to diagnose them and treat them. A number of pediatric therapies, physical therapy, speech therapy, occupational therapy, that really rely on the number of therapists, but there are way more kids who need this treatment. And then finally, in self-management, there is so much that we can do to teach our parents and teach our kids how to do some of the self-management techniques, particularly in mental health with cognitive behavioral therapy. And that actually extends to sleep efficacy as well, too. For our younger and more complex kids, remote monitoring for pulse and oxygen and heart rate, we need tools to be able to do this. So the technology trends look at algorithms, artificial intelligence, machine learning, and decision support tools. And that data really provides these technologies with multiple applications. We know that there's consumer-driven self-monitoring. I just look at my own iWatch and look at my steps and look at my heart rate and blood pressure and know that more consumers are using these tools. And then tools for remote monitoring for special pediatric populations is important. And some of this is what Rita had talked about. Artificial intelligence is really using computers and statistics to solve problems, make predictions, make automated decisions for tasks when done by humans typically requires intelligence and time. It's not that new. We know that we look at advanced statistics and there are classification algorithms. Is this A or is this B? This is actually used in a lot of the diagnostics that we see that are really facilitated by AI. We look at how much, again, a regression algorithm. We look at anomaly detection algorithms. Is this weird? We look at clustering algorithms. How is this organized? This is actually some of the unsupervised learning that helps us identify older medications for newer purposes. So machine learning is pattern-based. It are algorithms that find patterns in data and infer rules based on this, and that these patterns can be used for automation or prediction. And that machine learning is the most predominant form of AI that is used in medical equipment today. And if you look at this, we look at supervised, unsupervised, and reinforcement learning. Supervised learning is really where we get a number of the AI facilitated devices that are diagnostics. So they use classification and regression to look at, is it consistent with a diagnosis? Is it not consistent with a diagnosis? We use this in our everyday life as well, too. If anyone has ever been part of an identity fraud detection or customer retention, that usually is supervised learning, classification regression. Unsupervised learning is looking at clustering. It is taking data from multiple sources that may not be related to each other and finding out new medications that may have helped older diseases, older medications that are helping some of the newer diseases. When we look at unsupervised learning in our day-to-day life, not related to medical technology, one of the examples I use in the United States is that every month, one of the grocery stores that I go to sends me a group of coupons for things that I buy. And you're asking, how do they know this? Well, they know this from unsupervised learning. They cluster together your purchases with maybe your membership at that grocery store, and they're able to then recognize what it is that you buy and use customer segmentation. But so unsupervised learning in medical technology and pediatric technology is really important because it will begin to identify some of the newer uses for technologies we already have. And then finally, reinforcement learning is really looking at learning tasks and skills acquisition. This is used a lot with our surgical residents, where they are learning a skill. The better they do the skill, the more difficult skill is asked of them. In the non-medical area, this is really used in games, in video games. So you are able to get to level 2 and level 3 and level 4 based on what you have learned. And so we use this in a lot of our medical school training. When we look at look at software as a medical device, some of the inputs are patient data. These could be labs, these could be medical device data, it could be physiologic status. And then the algorithm will look at model-based logic or inference engines, and used on those knowledge bases and rules, there is an output, which could be a diagnosis, it could be a treatment, it could be information. So let's look at a complex algorithm. How does this actually work here? So we see two little girls. One little girl has a typical phenotype. The other little girl has the phenotype of a child with Down syndrome or trisomy 21. Well, if we look at that complex algorithm, what we are doing is defining what are those facial features that, if you put them together, could identify a child with Down syndrome. So what the algorithm does is it puts together epicanthal folds, upslanting palpebral fissures, brachycephaly, a flattened nasal bridge, low set smaller ears, a small mouth, and it looks at all of these different pieces of the algorithm, and then when we talk about training the algorithm, it takes multiple pictures of children to see who has this combination of facial features, who doesn't have this combination. So once this device is put together and the algorithm is actually put together, you can actually take a picture of the child with these facial features, and the algorithm sees a child with Down syndrome. Or you can take a picture of a child with typical features, and the algorithm sees a child with typical features. So this is actually in a device already. It is called Face to Gene. And this is an absolutely wonderful program that uses deep learning and computer vision and machine learning to actually try to look at taking a picture and doing a facial recognition of children with Down syndrome, with Cornelia de Lange syndrome, with many other different facial phenotypes. This is something that we can use in the field that is really important because not everybody has genetic testing capability. But you can tell using a diagnostic like this that a child may actually have a particular syndrome. Pediatric vision screeners have really come on the market as well too. This is a child that I see commonly. And because younger children tend to have very asymmetric epicanthal folds, you will sometimes look at this child and wonder if they have strabismus. And what has happened traditionally is these children have waited in line to see a pediatric ophthalmologist to see, do they have strabismus and do they need to be treated? Well, the pediatric vision screeners do is they use an AI algorithm to tell you whether these eyes are aligned or not. And this is using these tools of actually now prioritize the kids who really do have an abnormal finding and need to see that ophthalmologist. So one of the devices is called Go Check Kids. It is used and programmed on an iPhone, and it takes 30 seconds or less to do. You can use it as young as children of 6 months of age. And what happens is that you take that picture, you look at those children that are aligned. There are little voice sounds and bird sounds that those children pay attention to. And so you can take an accurate picture. And it can tell you whether that child needs to go on to a pediatric ophthalmologist or not. It is an amazing tool, could really be used in low resource settings to help to prioritize those kids who may actually have strabismus and may need to be treated. Now there's actually an FDA cleared device that uses AI to help to treat strabismus. So what has happened is traditionally these kids have waited in line to see an ophthalmologist to actually have glasses or patching done. And now there's actually an AI tool called Luminopia that is uses virtual reality headsets and helps to train that eye where the muscle is weak to make it stronger. So what happens when the child is looking at this is that their stronger eye is made a little bit weaker, their weaker eye is made a little bit stronger. And 1 hour a day for 6 days a week of using this device is actually as effective as patching the eye and much more acceptable by the kids. There are wearable technologies that really help out with physical therapy and rehabilitation. And these also will help for monitoring for children with medical complexity because you can get real-time notification if a child is having apnea, if a child's heart rate is too high or too low, if a child's oxygen saturation is too low. All of these things are coming through and are being used because they are facilitated by AI technology. This is something called the Embrace Infant Warmer, and this is relatively low tech. The warmer is heated up to a certain amount, a certain degree. And again, AI really helps with making it not too hot or not too cold. This is used in areas of the world where we don't have incubators and we don't have the actual nursery technology to keep a child warm. This will help out these preemies and lower birth weight children stay warm. And what the sensor does is it tells you when that child's temperature is changing and that they need to be either the warmer has to be changed or they need to be out for a while. There are smart bassinets. There is one that is FDA authorized to keep infants sleeping on their back, which is a guideline from the American Academy of Pediatrics. And because there's white noise and a little bit of rocking, these infants go from screaming to asleep in under a minute. They are being used now in homes. They're being used in hospitals to help babies calm. Particularly in the United States, we have a lot of trouble with babies who have opioid substance use, and it helps to wean them from the opioids, and it helps on nurse labor savings. There are some new home phototherapy systems. So these are for babies who are jaundiced. And these systems are blankets that mothers can carry. They can still breastfeed while that baby is in these bilirubin blankets. And the AI really helps with keeping the right amount of UV light there so the baby's jaundice is being treated, but there's not any toxic effects of the UV light. There are a number of wearables from hospital to home that are helping these babies who were premature be monitored at home and get out of the intensive care unit in a quicker amount of time. There's one that is really quite ingenious that looks at three different pieces of technology. The Vivalink EKG monitor, which is a small little patch that can fit on a baby's chest and monitor their pulse and their oxygen and other vital signs. There's a little sock called the owlet that actually will monitor a baby's pulse ox. And because it's fitted on a sock, it actually stays on the baby's foot. One of the problems with pulse oxes in premature babies is that the babies are little and they fall off. And then there is an axillary temperature, at least a guardian, that actually monitors the baby's temperature as well, too. And then there's actually a group called First Day Healthcare that puts all of these together and makes some fairly low-tech, lower cost instruments together that a baby can be monitored at home. And again, a parent can help to monitor this. There can be a physician or a neonatologist who monitors this as well too, so that those babies can go home a whole lot earlier. They can spend less time in the intensive care unit. They are less likely to develop infections and other things that happen in the hospital, and they can be home with a parent. There are also now smart pacifiers. These are sensor-embedded microfluidic channels inside the pacifier. And what this does is it can monitor the sodium and potassium for that baby just by having them suck on the pacifier. So it decreases the amount of blood work and blood sticks and can actually set off alarms if the baby's sodium or potassium are too high or too low. There is a new early childhood development assessment and autism diagnostic called Canvas DS. And what this does is it actually is prescribed by a clinician. There are questions that a caregiver answers. The caregiver uploads two videos of their child, one face-to-face so you can see speech and eye contact, one in a play environment. And then the clinician answers questions as well too. And what the algorithm does is it gives you a positive, negative, or indeterminate for autism for this child. And this can be done in days rather than most of these kids waiting 9 to 12 months for an autism evaluation. The detailed report is really helpful for the family as well as for the clinician because it will tell you where those child's strengths and challenges are. So you know pretty much right away if that child needs speech therapy or if they need occupational therapy or if they need more of a diagnostic workup. And this is just a picture of what the developmental challenge score shows because it's very important. What we know is a child with autism is one child with autism. They may have more challenges in behavior or speech or sensory. And this device gives you a clue that this is where the priority is with treating this child. Well, what about continued advocacy? We have some wonderful AI facilitated devices that are out there that can help with the diagnosis and treatment of many children. But first of all, we need the infrastructure necessary for technology to work. And one of the big pieces of that is the digital divide. Do we have children whose parents have access to Wi-Fi? We actually saw this during the pandemic in pediatrics with telehealth, with basic telehealth. We had families who had to go to McDonald's or another place where they could get public Wi-Fi in order to do their telehealth visits. So we have to keep this in mind for all of our families. We need to know and advocate for insurance coverage for some of these devices. It would be great for many of our families to have these, but as the technology is coming through, getting insurance to pay for them is another challenge. You always need a caring adult. The technology doesn't work by itself. You've got to have a parent who wants to be engaged with the child's condition and be engaged with what the child is doing to really make the technology work. You need your trusting relationships with your pediatricians, with your other clinicians to be able to make this work as well too. These have to be part of the whole care team to see what the data is like and see where this goes. And then there's finally interpretation and clinical context. None of these outputs can really stand on their own. They have to be interpreted with somebody who has actually seen the child, understands what the child is going through, and knows what some of the diagnostic and therapeutic options are for the child. With that, I'll say thank you.
Well, thank you very much. It is always an eye-opening, Colleen, your presentations. Now is Dr. Bharat Maheshwari, Associate Professor at Windsor University, Canada, and Mr. Brian Payne, Vice President on Health Alliance, will be presenting on artificial intelligence and HIPAA compliant learning management. Go ahead, Bharat and Brian.
Thank you, Dr. Luthra.
Yeah.
So it's a great pleasure speaking in this forum. And I think Rita and Colleen have already laid down the foundation for the care team. And what we present is Ontario OnRex Care Team, which is like a software platform, but it is supporting a care team. And how it does is brings together AI agents, learning management system, and virtual care as a whole activity which brings together all the clinicians for the main purpose of managing chronic diseases. Now, let me set the agenda here. I'll have to bring a couple of concepts here together. And it's very relevant here when Rita said that it is a multi-stakeholder STI event. Now, care is not a single person activity anymore. Now, and what Colleen did was bring in so many tools which can come together for delivery of care. And how they can come together is through a platform. And it can make things easy. It can provide a caregiver, like a parent in the pediatric conditions, take home something, they can do some things at home, self-serve. So many opportunities are here to improve care. But in our arena, what we did was we brought together multiple stakeholders. I, being a university professor, came in there, and especially from a business school, which is unusual, but important here because my area is technology management. But we also brought in computer science professors, we brought in doctors, hospitals, we brought in business folks, and we built a platform where care can be provided in a HIPAA compliant. Now, compliance is very, very important in healthcare. Data is important, but that data has to be governed in a proper way, that the privacy is maintained, and issues of individuals are not disclosed to those who do not need to know. And it is a very critical aspect here in delivery of care. But if you know, the chronic diseases, they are important. almost 75% of our resources in healthcare are devoted to chronic diseases. And we need different specialties to come together to care for chronic diseases. Not just physicians, but other clinicians are important. So how do we bring all of them together has been a critical limitation. And we brought together the multiple stakeholders and a platform which we were able to build and deliver this care better. So that's what we will be presenting. And I need to introduce here Mr. Brian Payne also, who is the Vice President with Ontario Health Alliance, which is a company which has built this OnRex platform, which is used for delivering complex care. And also, this is a platform which brings together several AI agents in its second version, which is coming up. There are AI agents to enable the clinicians. There are AI agents to enable the patient also. Now, that's very, very important part. In chronic diseases, patient is a big member of the care team because patient has to take those medicines. Patient has to do those exercises. And it is a long-term journey, and patient has to be motivated as well. So we'll set down the stage and introduce you to these aspects which are coming up. So what is an Ontario Health Alliance as a company? It is an event. It is a platform. It is something which brought together academicians, medical doctors, technology professionals, and business leaders also. Because one of the things which is challenging in the public sector mode is continuity, and establishing this is not a one-time effect, and there's a lot of risk involved in building a platform like this. So while we were involved as clinicians and academicians, we also brought in business leaders like Brian to take this forward. What it does, it is a medtech company which is developed through a collaboration, as I said, but the company has created an integrated, patient-centric, regulated, means compliant to all the government requirements in Ontario, a secure virtual care platform that supports care teams. A physician can be on this team, a nurse practitioner can be on this team, a dietitian can be on this team. All these clinicians can use the platform, which also has a learning management system built in it. Now, that comes out very interesting because in chronic disease care, there's a lot of learning needed. Patient needs to be aware, and patient needs to be educated, and patient needs to be motivated to follow the regimen, take the medicine on time, to do the exercises, change the lifestyle, and so on. So this is a system which was built and brought together to continuous professional development as well as changing the healthcare workflow. The challenge of chronic diseases is not an ordinary challenge. What we found out, data is prevalent that 75%, almost 75% of population in North America is facing in some way or other this challenge. Chronic diseases require collaboration between healthcare providers, patients, and their families for effective management and support of treatment plans. It's not easy. It is a long-term challenge. It is not one day. Now, people are also saying that, hey, can it be prevented? Yes, it can be, but awareness has to be up there. Once it is there, it has to be managed. But if it is prevented, if awareness is there, that's where learning management comes into a big play. And also, can the care be provided around the patient? Patient centricity is important. So prioritizing patients' needs to ensure that treatment plan aligns with their preferences. Now, in the modern world, we have become very, very busy, and our priorities are driven by our circumstances. In a life in a very big metropolitan city is very different than life in a farm. Now, patients are facing chronic diseases all over. Sometimes you can, if you look at Canada per se, where I am coming from, The distances are big. When people are living in remote areas, traveling for them is difficult. To see a clinician, they sometimes have to travel 50 miles. That's very, very important for them. So, can we reach the patients? Can all the team members reach the patients? Can there be a better coordination between clinicians and the patient, their support team, and the patient? How is everything brought together? So, these are the important things and challenges in chronic disease management. But we can deal with them by building a care team. But in certain situations, we found that while the patient was going to all these clinicians, but patient was not at the center of focus in the treatment plan. There were wait times. Sometimes they were waiting for a physician. Sometimes pharmacists and physicians were not able to communicate better. Uh, the education part was missing. Medicine, let's take an example of diabetes, which is almost turning out to be a mega problem for people around the world. Now that has to be doing something with our diet, something with our lifestyle, something with stress. All kinds of things are leading to diabetes. Now, how do we care for a patient with diabetes? Yes, physician can be very, very active in diagnosis. Pharmacists can fill the prescriptions, but a lot of times the prescription and the physician, they need to balance it. They need to titrate the need of the patient. And then diet can, in diabetes, can also be associated with the exercise level of the patient. Education comes in very big way in management of chronic disease like diabetes. So how can now we do it all? How do we get these care team members to collaborate and work as a single team? Patient is again center of it, but also a big part of it. Sometimes patients are aware, they are educated, but they're not motivated. There is a mental health challenge, or sometimes they're going fine, and suddenly in their journey comes a trauma event, or something happens where their mood goes low and they stop following the regimentation. The balance of medication and the regimentation goes haywire. What happens is uh, acute issues also develop. They have to be rushed to a hospital. So again, this is not a simple challenge. A whole team has to be there. And for this team to work together comes an opportunity of creating a platform. And that's where we came together to build one. And I'll come to that further. But what are the issues in diabetes and chronic disease management is they're complex. They're complex. They are dependent on everyday behavior. Things can go up and down very, very quickly if they're not managed. Now, management of large teams requires communication between those teams, repeated daily decisions sometimes. A lot of activities come in. Clinic visit is only one part of it. Now, clinic visit has to integrate with daily self-care. So here is an opportunity for providing technology to become the collaborator. Technology also comes in as a big part of the team here. And as Rita and Colleen described, there are tools which are available from AI. Not only data, but machine learning is leading to so many algorithms which are facilitating this complex activity. And but again, to bring them all together, we need a platform, we need AI agents, we need virtual care, we need adaptive learning, and all the aspects of chronic disease management, which we bring together in our approach. So let me explain now ONREC's approach. And Brian and his team has been big facilitators in us as a group in Ontario Health Alliance coming together and making and manifesting this. But if you look at it, there are aspects of chronic disease management. Physicians and clinician consultations and activities are one major aspect. but patient awareness is where it starts. So patient awareness can happen by chance or by education. How do we bring to the patient understanding of why patient is feeling in a way they are feeling, and why patient is suffering certain symptoms of diabetes or any other chronic disease per se. Uh, but then education goes into a higher level, that they are aware that, and they are motivated, and they're ready to take charge of them. Now, in this, AI-enabled OnRex platform can play a big role. As you see in the diagram, the AI agents within the OnRex platform can help the patient become aware. They can help the patient education become more interactive. So because you can put in a lot of workshops, and you can have a lot of examinations and tools and interaction on the LMS system, which has been built into the platform, which is learning management system is LMS. Learning management, it requires monitoring the progress of the patient education here too. Now, what level are they going? Uh, we have to see that if they are motivated more, they are going to follow the regimentations better, and the outcomes of clinician and physician consultations will be better, and coordination becomes easier. And also when we see that need and the load on the network becomes less. Now, there is another aspect here in North America, especially in Ontario. We have a huge shortage of physicians and clinicians. And even the shortages there, they are feeling burnt out also. Patients are sometimes waiting for a long time. And when patients are waiting for a long time, patients are up to making their own decisions. Google and other tools are becoming readily available. But sometimes when these tools are being used and knowledge is not interpreted and guided by clinicians and physicians, we can see a very, very bad side effect.
Mhm.
People are doing things they seem to think they are doing based on knowledge, but they are doing things which are ill-guided, and the impact and the result is very, very bad in a way that they can get into trouble and they can end up in hospitals. So what is the OnRex approach? What we were able to do in this platform, we were able to integrate AI, virtual care, and adaptive learning, all three together. Now, AI integration, what we are able to bring in is put in tools for diagnostic accuracy. Uh, when the clinicians and physicians are working on the patient and working with the patient, building their diagnosis, taking in the data, AI scripts come in very handy. Now, these AI tools can also not only point out if there are certain things missing, they can continuously help you and become your assistant in reminding you a few things. Mostly physicians, they have own their own templates for providing care. Now, with AI tools, they can customize their templates, and while they're going through their care process, can have some kinds of interactions and guidance as they go along. What it does is helps the physician become more accurate and more robust in their practice. Same way, the virtual care element takes out the distance. The
Mhm.
distance often in almost about 80% of the time, we are finding in chronic care, physicians and clinicians do not need to see the patient. Now, this is important in context of Canada, where the distances are very, very large. Now, when you do not need to see the patients, if you look at the total productivity, if patient has to travel all the time, which was a reality and requirement earlier, but in the virtual care environment, they don't need to travel. That saves a lot of time and energy for everyone. The patient is a big part of the care team. Now, when they can do these appointments very comfortably, do not have to travel, the appointments are less missed as well, and the care becomes better. Adaptive learning, that's very, very important. Like I have tried this. I monitored my sugar data using a device, and then that integrated that device with the system. So my sugar data is now integrated with the system, and clinicians can see the summaries all the time whenever we are seeing them. Plus, they can also be alerted if unusual activity happens on data, and they can come in and they can guide us in between. So overall, this is leading to better awareness, better knowledge, better motivation all across. What is AI doing? AI agents are available on the system for patient support. Now, patient support can be in many ways too: medication and appointment reminders, simple explanation of care plans, personalized lifestyle coaching when required, because we can do that with individual human coaches, but also we can assist those coaches and put some protocols and lifestyle coaching protocols into the system, and the patient can have them. This not only saves cost, but also improves the efficacy of the human individual who is now in short supply. In most cases in Canada, we are short of clinicians, we are short of physicians, and when we can move some patient support to AI, we relieve the load on the system. Clinician
Right.
support, visit
Right.
summaries, yeah.
I just wanted to add in, I think one of the things I know when Colleen presented, and Colleen, that was a great presentation, especially when we talk about remote monitoring in rural
Yes,
populations. For us in Canada, and I think you see it even across the United States, when you get into rural populations, you have that distance that
yes,
people have to go to. And you see that specialists, the amount of specialists available to rural populations is about 1/3 to 1/5 of what is available to somebody within the city. The ability to motivate the patient to maintain, to be their best advocate for their own healthcare is key. So when you see the term motivation coming through in our presentation and actually across our system, the idea behind that is to keep the patient centered in the middle so that the patient is their best own advocate. And we're trying things, you may laugh and say the Candy Crush phenomenon of, of rewarding. So one of the things that we've learned is that no matter what people are doing on an online device, if you can give them something, points, badges, stars, it actually does continue the motivation side. So I think that, that's something that is on the fun side of what the platform is, but it really is designed to keep the patient centered in the middle so that they will continue on the motivation side and the engagement side to do the things that they need to do with their physicians and with their core care team in order to prevent the disease or the regression of their health platform. So I wanted to make sure everybody understood the motivation side is just huge in this concept, especially since they don't have access like we do in a larger city. They don't have access to specialist care or even family physicians on a regular basis. Thank you, Bharat.
thank you, Brian. And that enhances the efficacy of chronic disease management and care. And especially in case of the rural patient, this becomes such a blessing. And a lot of Canada lives in the rural cities, rural farmlands outside the metros, although a lot of us live in the metros as well. But even in the metro, this becomes important. Even when distances are not much of a concern, just see the practicality of going to the clinic, waiting there, and that sometimes that can be a big cost for both the clinic as well as the physician, as well as the patient. So system support becomes very, very important. What we found, we are getting better engagement, we are finding better decisions, and we are seeing a lot of access improvement with this approach. In conclusion, what we are seeing that outcomes are much better when patient is part of the team. as well as clinicians are able to meet patient needs better from awareness, engagement to motivation. And especially in chronic disease management, this is a very, very important factor. And what we are also finding that multi-stakeholder engagement is critical, not just the researchers. What we need is physicians, we need the technologists, and we need the business people to bring it all together. And thank you so much.
Well, thank you very much, Bharat and Brian. Excellent, excellent work you guys are doing. Now from India, I have Dr. Manisha Jawahar, an obstetrician and gynecologist consultant in presenting technology in preventing maternal near miss. Can machines save mothers? Go ahead, Manisha. Hello, Manisha. Manisha is, oh, yes.
Just a minute.
Okay.
I thought I was to present in the end. So anyways, I just share the screen. Just a minute.
Okay. That's all right.
Hope it's visible and I'm audible.
We can't see you, Manisha.
Okay, just a minute.
Okay,
Is
good.
it okay now?
Yes, we can only see your head. Yeah, good. Go ahead.
My presentation is visible now.
Yeah, no, not the presentation.
It's visible. Presentation is visible. You can make it full screen if you want to.
Okay. Is it okay?
Yes, it is great. Thank you.
Fine. Preventing maternal near miss. Can machines save mothers? Centuries ago, Taj Mahal, one of the new seven wonders of the world, was built to commemorate the death of Queen Mumtaz Mahal, who had lost her life while giving birth to her 14th child. Mumtaz Mahal, Queen of India, died at the age of 38 years in 1631, probably because of PPH or prolonged labor, maybe infection or exhaustion from repeated pregnancies. The cause may be any, but the fact is, even empires can't save mothers from the dreaded complications of childbirth. And the stories have not changed. This is Mrs. Smita Patil, noted Padma Shri Smita Patil. She was a noted actress of India. She delivered at 31 years of age in 1986. And she thought, because she's feeling weak, she thought this is a common problem after delivery. And she was late in reporting, late in assessing that she needs a help, and she succumbed to septicemia. Serena Williams had a near death experience after giving birth. She felt shortness of breath after C section in 2017. She told the duty nurse that she needs a CT scan and a blood thinner, heparin, but the nurse ignored. She thought Williams is under the effect of pain meds. But Williams insisted for a doctor visit. Doctor did ultrasound of legs and said it is normal. The doctor also didn't take her seriously. But Williams was after CT scan. Finally, when she was taken seriously, CT scan was done and blood clot in lungs were detected. A life-saving surgery was done on her, which left her weak for a very long time of more than 6 weeks or so. So biases of health professionals also lead to maternal near miss. In 2017, in the same year, Beyoncé, one of the most decorated Grammy artists with 35 awards to her credit, a high net worth woman, fought with life because she developed high BP and toxemia all over her body because she had high blood pressure during pregnancy. Similarly, the Kim Kardashian, she is also a celebrity. She also had, sorry, in 2018, the Olympian Felix, she also developed preeclampsia. Kim Kardashian faced severe bleeding because of stuck placenta. And these are real stories of wealthy women with celebrity privilege facing the same complication, only the outcomes were different because uh, they had availability of resources, they could reach, they could get the good care, specialized care in time. India's daily maternal metrics. India is a population of nearly 1.5 billion, has uh, nearly 2,000 maternal near miss every day, and nearly 70 to 80 deaths are seen every day. And this is after a 32% decline seen in last 7 to 8 years in the maternal mortality. Most of the studies have time and again proved that nearly 80% of near-death events are witnessed by women from rural background or those who are struggling in below poverty line status. If we really want mothers to live and don't want to make more Taj Mahals, it is important to avoid all delays at any cost. And AI can definitely help us achieve our goal because most of the maternal near miss or the near death event cases are due to delays like delay in recognition or underestimation of severity leading to delay in reaching health facility because of delayed referral or delayed thought of seeking help. Now, AI can fix it to a great extent because it can see the patterns which humans may miss. AI can give objective scores, which is as good as decision or order to move in a particular direction. Because many delays happen because we fail to accept that something severe would happen to me or to my patient. Whereas AI is out of this bias and it directs towards early referral and thus avoids reaching the near death experience or MNM stage. All stages of delay can be corrected, and good news is this is the first stage of delay in seeking care. By the risk prediction apps, we can combine the antenatal care data like hemoglobin, BP, parity status to label high risk pregnancies early and push reminders. Wearables and home devices like BP curves, pulse, SpO2, these can be very helpful. They can trigger automatically some alerts for especially for women, those who are away from, as Dr. Bharat just now pointed out, those who are away, those who are in rural settings, they need to spend a lot of time in having a health facility. Then there are behavioral nudges like if timed SMS or local language vocal response is given, this symptom, go now. These alerts can be set in the rural, their own language. This will reduce hesitation in reaching the health facility because most of the time we are very confident that everything good is going to happen to us. Impact of maternal near miss on early recognition. So faster decision making, fewer patients arriving in extremes. The second delay in reaching a health facility can also be managed by AI, a smart referral routing. We can have apps that choose the nearest capable facility. We have referred the patient to one particular facility, but when the patient reaches there, it is found that that facility doesn't have any beds. So the time is wasted from this is golden period and the treatment is delayed. Ambulance optimization can also be done by GPS tracking, traffic prediction, so that travel time is cut down and the help can be reached very early. Bed and blood dashboards. There are ICU beds availability, whether this hospital has blood transfusion facility or the blood units of particular group are available. All these can be also monitored by AI. The teletriage en route. The paramedics can connect to obstetricians for pre-arrival stabilization. As we were just listening, we can have online consultations. So this is extreme emergency where every minute matters. So how this impacts maternal near miss? Minutes saved in transit and correct first destination. So fewer deteriorations. Delay in receiving adequate care is the third delay. This can also be managed by AI by having early warning systems, by continuously monitoring vitals and lab reports. The red flags are seen before collapse occurs. Sepsis, eclampsia, hemorrhage, whether stepwise protocol or massive blood transfusion is needed, how it should be given, PPH bundle, magnesium sulfate for eclampsia, smart monitors are there, automated urine output, BP, tracking is there, portable ultrasounds for rapid decisions, and all the reports are amalgamated to give answers. Team performance technology. These are digital checklists for golden hours actions and simulation of analytics to improve drills. What is the impact? Definitely faster diagnosis and standardized response will prevent progression to organ failure. So even if a woman lands in maternal near miss, long-term sequelae would be less. And I tell you, this is not difficult. India is having one of the most robust data. We are having Ayushman Bharat Digital Mission, then making of Aadhaar card, then we have SIR, whereby we have recorded all details of all the people who are voting. Only thing is, these tell us about how many women are there, how many women are alive, how many women survived pregnancy, how many women died. Unfortunately, they don't tell us when complication will occur. If this information is integrated and the Anganwadi workers and the earlier PHC workers are taught how to use this data in getting the numbers of all adolescent girls of their village. This can be definitely used in vaccination in reaching up to the full 100% mark of vaccination also. But then we have data of adolescent girls, we have data of women, we know when the woman is getting married, we know when she's conceiving, so that they can be tracked. The only problem is because of data privacy rules and certain things, these data are not shared with the health facility. The Aadhaar card, which is the health record, a very aggressive step of Government of India, but unfortunately its reach is as of now very less. So if we want 60,000 these women who are affected yearly to survive, then we definitely need to incorporate AI to help them survive. And I tell you, approximately 60 to 70,000 women die of cervical cancer every year. But 25 to 30,000 women die of pregnancy every year, and nearly 3 to 4 lakhs of women are left in maternal near miss state or near death experience, and many of them have sequelae for lifetime. And remember, these women are very young. They are at the age when it is very productive. and we are leaving productive women unproductive. So it is equally important to have and think about AI in saving these women who just want to be mothers. Thank you.
Thank you, Manisha. It was very eye-opening. Now is from our hometown, David DiSabito from Western New England University. He's presenting RAG, RAG. He will explain it. And ag- agentic AI transform clinical medicine and surgery safely. Go ahead, David. Hopefully
Uh,
your slides work.
can everyone hear me okay?
Yeah,
Thank
we
you.
can hear you, but let's see your slides work.
Okay, I think I put the slide on. The share is on.
Share is on my side too.
Can you see my slides? No?
No,
I'll stop the share and
We
reshare it.
can
I can see your slides.
we can see your slides, David. I think there are two views. There is Rita's screen and David's screen. So Rita, if we can go to David's screen on your Zoom, you can see the slides.
okay. Um,
Yeah,
Stop
we are able to
share.
see
Should I press
slides.
the stop share?
No, no, don't press anything. If you go to the hover it on the top where the
David
top of the
screen.
screen,
Yeah,
you see Rita's screen and you see David's screen. If you press on David's screen, you will see slides. If you see Rita's screen, you will see just the presenters.
it says my screen. Okay, I think we got it something. Go ahead, David.
Okay. Thank you, Rita. Thank you, Women's Health. And I'm pleased to be here, and I've been enjoying the presentations. Thank you, presenters, for sharing your knowledge. What I want to present today is can retrieval augmented generation and agentic AI transform clinical medicine and surgery safely? So the first question here is, what if RAG and AI agents could augment what you already do well, keeping you in charge and making you more informed, efficient, and effective? One of the common themes I heard through all the presentations today was the gap between resources and care, and mainly that there's not enough humans to go around to take care of our folks that need health care. So, what if AI agents could make you more informed, more efficient, more effective without replacing your clinical judgment? So, these are the three advantages that RAG and agentic AI can provide to providers, and this goes for any business, but this presentation is really focused on healthcare. Um, so the I just want to ask these questions. What if clinical answers came grounded in the latest evidence, not just health care providers' memory? Um, what if the navigation, paperwork, and follow-up were handled so you could stay more focused on the patients in front of you? That's huge. Um, what if every recommendation was reviewed? The agent prepares and the clinician decides. Could this be a model that earns trust? So these are some really good questions that I think RAG and agentic AI ask us to ask ourselves. So um, one
I
in
just
every,
lost the presentation.
you lost the presentation. I'll reshare it.
What happened, David?
I think I reshared it and then it unshared. Wasn't me that unshared it. We'll try it again. It says Rita's sharing.
No, my screen is on.
So maybe if you stop share, then I can start share.
My screen, okay, if I stop share. One participant, all participant can share. Uh, Stop share. Okay, and let me start again, I think.
No, no, no. Let me share now.
Oh, okay.
I think that'll work.
Yes, yes, perfect. See?
Okay. So the gaps that RAG and agentic AI are uniquely positioned to close. So there's large gender imbalance in data sets used to train clinical AI. Um, one woman and three men. So that can be produce worse diagnostic accuracy for women. 287,000 maternal deaths could be prevented from better post-discharge follow-up. 70% of clinical notes, standard AI never even reads. So that poses this question, could RAG and agentic AI address each of these gaps? And I think the answer is yes, if we choose to design them that way. So how does this all fit together? Well, the you know what we normally think of AI in older terms is the machine learning pattern detection. So it's been super powerful and useful uh, to help with finding patterns and helping with clinical decisions. Generative AI is useful. Um, it helps draft notes and summaries that now you can do in seconds instead of minutes. I've had the experience of working with my cardiologist, um, and he asked me to if he could record our appointment, and I said yes, and so the AI transcribed both of our um, his questions, my responses, created a really nice summary of the appointment and what we were to do next, and actually posted notes to his internal system. So the ability of the AI to listen and to summarize is amazing. One of the things that we've seen and all of us have seen is the hallucinations and the AI slop. So this is where this idea of RAG really is important, because RAG can virtually eliminate the AI slop by referring to documents that you trust that are associated with what your goal and mission is at the time. So the AI um, works with your basically knowledge base or local document or database library to construct answers that are related specifically to your questions rather than making stuff up. So RAG is really important. Um, and finally, agentic AI allows us to have the AI work virtually as a person doing a job, taking a workflow from a starting point, and putting together several tasks, including perceiving and digesting and making decisions. So it can be guided to do work of humans. Um, so it's very, very powerful. So what's RAG and why does it matter at the bedside? A clinician, step one, clinician asks, what's the recommended postpartum hemorrhage protocol for this patient? With RAG, you could um, retrieve, what if the current WHO and ACOG local protocols were searched in real time, and then augment that um, and respond and cite. So the thing that's very powerful about RAG as opposed to typical generative artificial intelligence is RAG augments the artificial intelligence with your knowledge base or document library or database and answers citable, traceable answers from an approved source. So it can say, based on this standard page, whatever, here's your answer. So rather than just relying on memory, it can go back to source documentation. So the other thing about RAG that's really cool and important is that it can stay current. You can put the latest research into your knowledge base or RAG library. So one of the things in all of the AI work that I've done that we always keep coming back to, and it seems to be consistent in all the environments, is keeping that human in the loop. In other words, you don't want to put out work that you wouldn't sign your name to. So the AI agents can assist you, pretty much act like secretaries. They can do a lot of the research, they can do a lot of the work, they can do a lot of the summary, and you can have the final say. As in my description of when I met with my cardiologist, the cardiologist didn't just approve the notes, he read the notes first to make sure that they were accurate, and that all of the facts were accurate before approving of the notes. But the AI agent pretty much handled all of the secretarial and sort of paperwork. So this is why this idea of AI and RAG and agentic AI are so powerful. Um, the idea here is, it starts with the human and ends with the human. Um, the agents can actually do work um, as if they were hired help, um, and they can be trained to escalate when things are uncertain. So the RAG will enable them to be more certain than just using straight large language model, um, and they can be trained to escalate when they are uncertain to make sure that they stop the process and get the humans involved. So pretty much a RAG-powered agentic workflow with human oversight where it matters. The first step is, what does the patient or clinician need right now? The RAG retrieves current guidelines, protocols. What do they actually say? The AI can interpret the context, language, setting. Are things fully understood? Can make recommendations. What are the best evidence-based options for this clinician act? Could the agent book, remind, draft, route, or follow up and escalate when the agent should step back and hand off to a human? So where best would the clinician review, approve, and retain full authority? And that's the workflow design question. So we look at a woman's health example. What if the agent listened in real time, retrieved the ACOG protocol, the moment postpartum bleeding was mentioned, flagged critical symptoms, and surfaced the triage recommendation, waiting for clinician's approval. So surgical example, what if a contradiction was flagged and a personalized safety checklist prepared before the first incision, reviewed and signed off by the surgical team before proceeding? So these are some cool examples where RAG and agentic workflows may be useful. So where these could make a real difference: maternal safety. Could early signs of postpartum hemorrhage and preeclampsia be detected sooner? RAG systems demonstrate up to 18% accuracy improvement in critical medical question answering with documented applications in obstetric triage. Surgical preparation. What if a contradiction was flagged and a personalized safety chip was prepared before first incision? Chronic disease management. What if women with hypertension or diabetes received guideline aligned follow-up prompts, assisting your staff? Diagnostic support. Could bias be corrected with scoring tools and peer-reviewed differentials to reduce late diagnosis? We know women are experiencing, and the RAG support can be like amazing in these situations. Discharge planning. What if plain language discharge instructions were drafted and follow-ups scheduled automatically, or sign off before patients leave? Clinical research. What gaps in women-specific clinical evidence might we finally surface if literature review took hours instead of weeks? So can this be done safely? The guardrails that matter. We want to keep human in the loop, be grounded in evidence, check for bias, protect data privacy, and create an accountability chain. When an AI agent makes a clinical error, who's responsible? So can this be done safely? Yes, if it's designed to be grounded, trusted, local, private, inclusive, and human guided. So who benefits? And the equity we must not ignore. 2.2 billion people don't have internet access. 885 million women in low and middle income countries are unconnected to mobile devices. Only 23% of people in low income countries use the internet. So there's equity risk. Agentic AI requires device, internet access, and digital literacy. None of these are equally distributed. So if adoption follows existing privilege, could these tools widen the very gap we're trying to close? It's a really great question. So what would it take to make this work equitably? Connectivity, infrastructure, community-led design, multilingual support, data privacy protections, and accountability mechanisms. So how and for whom? RAG virtually eliminates the hallucinations and AI slop. Agentic AI uses trusted knowledge and turns it into real-world action, booking, flagging, following up, and escalating. Clinical authority stays with the human. RAG and agentic AI are augmenting tools that make healthcare providers more informed, more efficient, and more effective. Together, they close the gap between knowing and doing, where women's health outcomes are won or lost. The technology is capable, the evidence is here. Can we direct RAG and agentic AI to where the need is greatest and design it with the communities it aims to serve? I think that's a great question for us. So imagine a postpartum mother who cannot reach a clinic. What if an agent prepared her telehealth visit, surfaced the latest guidelines, and followed up, all reviewed by her clinician? What if a surgical team could dramatically reduce missed contradictions because an agent reviewed the full chart and flagged it for the surgeon a sign off before the first incision? Um, what if a community health worker in low resource setting with a RAG powered assistant in her pocket, grounded in local protocols available in her own language and designed to serve the women most often left behind? So it's not necessarily a technology question, it's design, access, trust, and equity question. So that's my presentation. Thank you all for your support.
Well, thank you very much. Um, and we will meet again. Our time is up, and if last 1 minute, if anyone wants to make the last statement, please go ahead.
I thought it was really cool the way all of the presentations sort of melded together. There was a lot of
Yes,
cool
yes.
overlaps.
Yeah, we try to balance it. It takes a little while to make sure. Brian, come again. And next time the speakers don't shut your microphone or your pictures. I don't know this time. It's very few slides. Colin's slides went beautifully. Let's stop recording.